Hi, good evening. My name is Daniel Zamora, and I'm a hepatobiliary and transplant surgeon in Mexico City at the Navy Armed Forces Medical Center. I'm going to be coordinating the clinical case, which is going to be a hiliar cholangiocarcinoma, which will be presented by Dr. Rosen, whom alumni, we call him Chuck. Dr. Rosen is well, if I may say it, senior surgeon, and he's really the professor of us all at Mayo Clinic in Rochester, Minnesota. He's a transplant surgeon with a great career. He's going to be presented one of his many cases. And in the panel, we have Alan Contreras, who's a transplant surgeon in Mexico City at the National Institute of Nutrition. Dr. Miguel Mercado, who's the chairman of surgery at the Instituto Nacional de Nutrición in Mexico City. Dr. Tim Pavlik, who's an oncologic surgeon in Ohio University. He's actually the chairman of surgery there. And Dr. Yoshihiro Sakamoto, who's a surgeon at Kyorin University in Japan. Welcome, everybody. And I'm glad to have you here. And thank you for participating in our meeting. And I'm giving the word to Dr. Rosen. Chuck.
Thank you, Daniel. It's a pleasure to be here, and I want to thank you and the organizers for inviting me. I wish, as I'm sure all of us wish, that we could be there in person and be enjoying each other's company in addition to this wonderful symposium. I'm bringing up a case of hiliar cholangiocarcinoma for discussion, and I do not have any disclosures. And this was a 60-year-old male that was referred to Mayo Clinic. He had had a transluminal biopsy that demonstrated cholangiocarcinoma arising de novo, and it had been deemed unresectable by a very experienced hepatobiliary pancreatic surgeon at a very large academic medical center on the East Coast. His symptoms began in November of 2002 when he just didn't feel all that great. He wasn't having any symptoms other than that. He went for a physical examination, was found to have an elevated alkaline phosphatase and GGT. He was being followed for hemochromatosis at the time. And then in March of 2003, the lab abnormalities persisted and an MRI was done, which showed a hiliar mass consistent with hiliar cholangiocarcinoma. It took a couple of months, but eventually he developed jaundice and underwent a left percutaneous transhepatic cholangiogram with placement of a stent across the hiliar tumor. The right side was left undrained. The biopsy showed suspicious cytology, or the brushings showed suspicious cytology, and the biopsy demonstrated grade 3 of 4 adenocarcinoma. Unfortunately, this procedure was complicated by hemophilia requiring transfusion. He did have a biopsy of the unaffected liver, which showed ductular proliferation and periportal fibrosis consistently, consistent with biliary obstruction and attributed to biliary obstruction and not to his underlying hemochromatosis. And you'll understand why I picked such a case going back 17 years in a little bit. He was referred to Mayo Clinic and underwent evaluation with us. His medical history was significant for hemochromatosis, for which he was on appropriate medical therapy. He had had an appendectomy, hypertension, and had bleeding duodenal ulcer 30 years ago. He also had weight loss, about 30 pounds, fatigue and weakness, and intermittent jaundice and pruritus, which was alleviated with placement of the tube and changing of the tube. He also had an elevated alkaline phosphatase and GGT. His bilirubin was down to close to normal, 1.3 after intubation. His creatinine was normal, as was his albumin, and his CA19-9 was 134. Per our usual workup, he underwent a CT of the abdomen at that time, along with an MRI, cholangiographic study through the tube, and then endoscopic ultrasound with fine needle aspiration of the regional lymph nodes, but not the primary tumor, which is our practice. He also had a CT of the chest and a bone scan, which didn't demonstrate any evidence for metastases, and underwent evaluation for transplantation as well. He was found to be somewhat frail, but really didn't have any other contraindications for transplantation. Now, his CT demonstrated right liver atrophy with compensatory left liver hypertrophy. His left-sided tube was in place and extended into the duodenum. It decompressed the left ducts, but not the right. He also had narrowing and occlusion of the right portal vein, and what was thought to be numerous tiny nodules throughout the root of the mesentery and adjacent to the pancreas and stomach, consistent with what was quoted as extensive mesenteric seeding. We really didn't appreciate that, but that was the reading at the time, and I pulled a couple of CT sections for your review. As you can see here on the image on the left, there's a narrowing of the portal vein. The PTC tube is in place. There's a right liver atrophy and dilatation of the intrahepatic ducts on the right side. A little pneumobilia in the gallbladder as a result of this percutaneous studies, and there wasn't a tremendous amount or any appreciable regional lymphadenopathy. With the MR, it showed a 2.2 centimeter mass in the hilus, consistent with cholangiocarcinoma. It was thought that the mass encased the common hepatic duct and extended along the right and left ducts. It encased and included the right portal vein. There were multiple tiny nodules in the liver consistent with abscesses, and the mesenteric nodules seen are interpreted on CT were not seen on MR. Here's a couple of pictures demonstrating those findings with the, again, the portal vein occlusion or near occlusion on the right side, and reconstitution of the portal vein below that narrowing, but it was clearly encased. Here's the bile duct here, some hyperenhancement alongside of it, and the mass was thought to extend into this area as part of the caudate as well. We also did a tube cholangiography, which demonstrated the left-sided tube. And unfortunately, I could not find any pictures from the outside which demonstrated the original percutaneous study without tube placement. But as you can see, there appears to be a narrowing up into the tube, occluding everything around the tube in the area of the mass on the MR, consistent with hilar cholangiocarcinoma, extending a bit onto the left duct, and the right-sided ducts are not visible. Importantly, for our transplant protocol, the cystic duct was patent. He also underwent endoscopic ultrasound and fine needle aspiration. The nodules that were seen on CT were not appreciated on EUS. We always do a fine needle aspiration of the perigastric, peripancreatic, and hilar lymph nodes, even if they appear benign. And that study was negative. There was no evidence for malignancy. And very important for us, we specifically did not do a fine needle aspiration of the primary tumor mass. In our transplant protocol, that procedure has been complicated by peritoneal seeding or recurrence each and every time it's been done after transplantation. So our decision was to proceed with neoadjuvant therapy in anticipation of operative staging and subsequent liver transplantation. His blood group was O, and we anticipated a 6 to 9 month wait at that time for a deceased donor organ. And he was begun on neoadjuvant therapy, which is our typical 4,500 centigrade of external beam radiotherapy with 5-FU chemosensitization, along with 2,000 centigrade of brachytherapy. And after completion of that, capecitabine, which was intermittently tolerated until he would await transplantation. I thought maybe we should stop there, because certainly, Daniel, there might be some discussion about whether or not this tumor is indeed unresectable, or whether or not our decision to proceed with transplantation was appropriate at that time.
Yeah, sure, Chuck. I think that we can go at multiple points and then direct some questions to our panel. I would like to ask Dr. Yoshihiro Sakamoto, if you can turn your mic on. I would like to ask you about your experience on the resection of hilar cholangiocarcinoma on patients with underlying liver disease. Because
yes,
this patient has hemochromatosis.
Yes, thank you. I think this case will be resectable first. Should be a hilar cholangiocarcinoma, bismuth type 3B or 4. And the portal vein is involved by the tumor strongly, severely. So we need to, but the right liver was very atrophic, and we do not do the preoperative portal vein embolization in this case. And I think we can do the resection, upfront resection in this case. And fortunately, the lymph node metastasis was not found on the fine needle aspiration before operation. So we plan to do the right hemihepatectomy with bile duct resection and the portal vein resection and reconstruction in this case, and also the nodal dissection.
Thank you, Dr. Sakamoto.
Thank you.
Dr. Pavlik, what's the difference in the clinical course and final outcome of patients with hiliar cholangiocarcinoma who have a mass-forming lesion in comparison with other patients?
Yeah, thank you, Daniel. So, you know, first of all, I just want to say, I mean, I kind of agree with Dr. Yoshihiro. I was wondering what Chuck thought. I mean, I thought this was potentially resectable. It looked like it didn't go that high up on the left. So, I mean, I would think in preoperative planning that I could get above it on the left. And even though the portal vein was involved, it looks like that you could easily resect that, or even if you had to reconstruct it. And there seemed to be adequate volume on the left. And then the other thing, it seemed like you biopsied the liver, and even though he had a diagnosis of hemochromatosis, at least I think I heard what you said was that there was no underlying parenchymal injury related to the hemochromatosis. So I think all those things combined, I think potentially resectable. I think, Daniel, to your question, sometimes it's hard for me to figure out if something's like an intrahepatic cholangiocarcinoma that's growing down into the hilar plate, or whether it's a hilar cholangiocarcinoma kind of growing up, if you will. And so sometimes I think it's frequently difficult to figure that out. I think that, you know, in my experience, a mass-forming intrahepatic cholangiocarcinoma does worse in general than hilar. I think of hilar as being more of a local issue, and I think that's why perhaps it's more amenable to transplantation than not. And I think that's also why there's a cutoff with the transplant criteria of a size, because when there's a mass there, as it gets bigger, obviously the concern is that the prognosis is going to be worse long term.
Thank you, Dr. Pavlik. Dr. Contreras, this patient has had a portal vein involvement. Would you like to comment about the involvement of the portal vein? Is it an encasement of desmoplastic reaction, or is it a true histological invasion of the vein? Or how would you manage that as a surgeon before and during the operation?
Thank you, Daniel. So this is a very important question for our audience, because back in the days, our oncologists used to say, there is no way we're going to go into surgery with these patients, because they used to assume that this was every single time probably related to tumor invasion and vascular invasion, and they tend to do poorly. But well, we have new evidence from our folks in Asia that has proven that not all those patients that have these encasements, because it's a very, very bad tumor, and they do have a lot of desmoplastic and fibroblasts around the tumor that probably encase the vascular structure. So we know that this is not a contraindication anymore. That has changed, and we should pursue to trying to do an R0 resection. So if we think that at the end of the surgery, we are very confident to say this is going to be an R0 case, we should probably go ahead and try to do the resection. So I'm just curious about, Mayo Clinic is a very experienced center with high volume. The reason they decided to go for transplant was not the underlying or the possible underlying liver disease, because this patient has hemochromatosis. We don't have a lot of experience with that. But it seems, as Dr. Pollack says, that it's not part of the decision making. It was not like really the patient had like a chronic liver disease. But I assume they probably have other images when the tumor looked pretty bad. What we just saw, as Dr. Rosen said, it doesn't look that bad. But so now when we talk to our surgical oncologists, we are very emphatic saying that probably most of these are just encasement because of desmoplastic reaction, and we should try to get the patient R0. And having said that, that's probably the reason why some people have lymph nodes involvement, and also some other liver lesions that may be little abscess instead of a metastasis.
Thank you, Dr. Contreras. And Dr. Mercado, before giving a chance to reply to Dr. Rosen, would you like to talk to us? Because the true question here is, if you are considering that this patient may be resectable, if you do a resection, you have to aim for an R0. So what would be the difference between resecting an hilar cholangiocarcinoma with an R0, an R1, or an R2, Dr. Mercado?
He's muted.
You need to turn on your mic. Thanks.
Thank you. This is a very interesting case. And the bad thing is the underlying hepatic disease. I was trained in a center many years ago where they were very aggressive with this kind of tumors. And the bad thing in this case is that it has a very large segment 4 and a very large caudate lobe. And that will be a difficult resection, but these cases, at least in Germany, and I have tried very few cases in 25 years here in Mexico, but I cannot find really these suitable cases in which a portal vein is resected, is done a complete resection, leaving only segments 2 and 3, making Rosen section of the remaining bile duct from segment 2 and 3, if necessary, done 2 anastomosis there. And because resecting the portal vein is possible, as all of you know of that. I am the less experienced of all of you, but I think that resecting the portal vein can be done in this case. And although he has hemochromatosis, he has done a very nice hypertrophy of the left lobe. So it's not really the behavior of an advanced liver disease. And I know the wonderful experience at Mayo Clinic, but in many, I think the 99% of the world, liver transplants are not available for cholangiocarcinoma. I think that here in Mexico, only one case happened. Contreras, only one case here in Mexico, yes, done with the liver transplant. But I know that this protocol from well-renowned from Mayo Clinic, and if you have this possibility, the possibility of really an R0 resection, which will be total hepatectomy and liver transplantation and so on, we will take care of hemochromatosis. But I will be afraid with dealing with this segment 1 and segment 4. We'll think about it. It's the only thing why I will be a little bit scared about resecting. But if I will try for resection, I will only leave segments 2 and 3 and did a right extended hepatectomy. I will do that. And I think in our experience, most of the cases have microscopic invasion. And I have heard in one of the HPB congresses that positive margins depends with the friendship of your pathologist. If you're a very good friend of the pathologist, he will say you have negative margins. But if the pathologist makes a deep inspection of the tumor, he will find tumor 1 centimeter ahead of the resection with perineural invasion and vascular invasion, microscopic, making impossible an R0 resection. But here in Mexico, from the beginning, I will try to do a right extended hepatectomy.
Thank you, Dr. Mercado. If I may add to his comment, and I think that it's important to remind that there's a microscopic invasive carcinoma component that can extend 1 centimeter beyond the stenosis that can be seen on imaging studies, and the in situ component can extend 2 centimeters and in some cases up to 4 centimeters beyond the stenosis. So I think that's something important to keep in mind. The fact that the stenosis is not affecting the full left duct doesn't mean that the tumor is not there. And I think that I agree with Dr. Rosen in the sense that the best chance to get a definitely RCO resection in this case would be a liver transplant. But I would like to ask Dr. Rosen, what's the process at your institution to decide that a patient is unresectable? I mean, how many surgeons must evaluate the case? Is it a multidisciplinary case rounds, or how do you decide that, Dr. Rosen?
Well, you've all brought up excellent points, and Daniel, you have a questionnaire. You know, we have a team approach to patient care, so we were partnering with a referring hepatobiliary surgeon who's quite experienced, a name that you would recognize. And also, I work very closely with our hepatobiliary surgical group. Back in 2003, it was almost exclusively Dave Nagorny, but now, of course, we have Sean Cleary and Rory Smoot and several others. But the question, I think, that I'd really like the panelists to ask for me, or to answer for me, are two questions. Number one, looking at a case like this that will require a portal vein reconstruction that you know extends up into the left duct and that you know that extends it into the caudate, what's the likelihood that you will achieve an R0 resection on the first cut? Because we've already shown that if you have an R1 resection on the first cut and you take another margin and you achieve an R0, that's a bad prognosis and it behaves as an R1. You may disagree with that, but I would like an answer to all of you to just estimate what the likelihood that you'll achieve an R0 resection would be. And if you were to achieve an R0 resection, what would you estimate the 5 and 10 year survival?
Would somebody like to answer that?
I'm sure I'll be happy to answer that. So I think it is low. And I will preface my comments as Dr. Mercado said. I think if livers were ubiquitous, I think transplantation for most or for all. I think by the letter of the law, at least, and when I looked at it, I think it's potentially resectable. But I completely agree with you. And with everyone, it's going to be a very difficult case. And the odds that you're going to get a negative resection, I think, is low. I'm just making this up, but I think in the range of like 20%, maybe like 80% chance it's going to be a positive margin. And I think the 5-year overall survival is probably going to be in the range of like 30%. That's what I would think. So I think transplantation is probably the best option, right? Because I think the odds that you're going to extirpate all the disease and get it all out, and the guy has some hemochromatosis, I think that's the right choice. I just think that when we're talking about transplant for truly unresectable, does this meet unresectable criteria, or is it resectable, but there's a low chance that you're going to get an R0 margin? And to me, there's a continuum there, and there's a grayness there. And where do you draw the line? I don't know if I'm making sense or not, but that's right.
I think that makes absolute sense. But the thing here is that at least the rationale that I would follow in the case is which path is going to lead the patient to a definite R0 resection instead of the chances that you are explaining yourself. I think that's a good point. And somebody else wants to answer Dr. Rosen or ask him something else?
I would like all of you to answer because I would just like to know what you think. Alan is raising his hand.
Dr. Rosen, I definitely think, there is no bigger operation to get a patient into R0 like liver transplantation. This is the rationale behind also transplanting patients because of colorectal metastasis. I'm totally agree with you. This is like a very advanced tumor. The caudate has this kind of involvement. You can assume that because just of the nature of the anatomy of the caudate ducts going in the cranial part of the portal vein, you can assume you're going to have a lot of microcystins along the way to the right portal vein and probably the right, the left and the portal vein on the left duct. But I have a question to ask you, and this is related to the kind of transplants and the activity we do here in Mexico and Latin America, because we have a lot of folks from Latin America. So you guys have a very developed and sophisticated protocol. And I hear you once in a conference that you said that liver transplantation was probably the best adjuvant therapy after giving so much chemotherapy and radiotherapy and having all this protocol. So what would you say to any of our surgeons here in Latin America that they would say, okay, let's try and do a liver transplantation, because the reason you are providing is very right. Maybe this is going to be the best R0. So what would you say if they don't have the full protocol, just say part of the protocol, either chemo or radiotherapy or just parts of it? Would you advise to go ahead and do a liver transplantation trying to achieve R0?
Yeah, I don't think that liver transplantation as primary therapy has any role in the treatment of cholangiocarcinoma as the primary treatment modality. You're absolutely right, but I think it's crucial, and I would just want to go back and maybe have Yoshihiro and Miguel just kind of give a ballpark estimate of what you think the likelihood of an R0 resection would be, and if you achieve an R0 resection, what's the 5 and 10 year survival?
Okay. This is a case of the hilar cholangial, very locally advanced cancer, and the right portal vein is involved by the tumor, which will worsen the prognosis. So even if you do the R0 resection in this case, I think the 5-year survival will be 30% in this case. If there has a lymph node metastasis, it will getting down, I think.
So for an R0 and 0,
30 to 40%, I think.
30%. Okay. Dr. Mercado?
Yes, so this is a very important question and difficult answer. We just published in a local journal in Mexico our experience with this type of cases. And we found that in definitive analysis of the specimen, more than 50% of positive margins, not a frozen section, a definitive analysis. And the survival was 30% for 5 years. And this, I agree fully with you that it's very difficult to get free margins in these cases. I agree with you that liver transplantation is emerging as a really a good option for these cases. In our experience, to have negative margins is less than 50%, less than 50%. I had a very nice case for a very famous bullfighter who had they were thought that he had a bile duct injury. He had jaundice after a cholecystectomy, and I removed the stenosis, and he had a cholangio, really a Klatskin tumor. And I didn't know that at the operation, and he lived, I resected him, positive margins, and he lived 3 years, but he died because of a bull injury, not for the cholangiocarcinoma. He died because of a bull injury. It was a very famous bullfighter in Mexico called El Pana.
So thank you. The reason I was pressing you on that question is, let's say that your survival after an R0 resection was 70%, not the 30, 40, or 50% I heard mentioned. Let's say it's 70%, but your likelihood of achieving an R0 resection is only 70%, which would be 3 times some of the percentages that you've already quoted to me. So the intention to treat survival in a group of patients then would be 70% of 70%, which would be 49%. So unless you have a 70% chance of getting an R0 resection, and you can achieve 70% 5-year survival with an R0 resection, the intention to treat for operating on this patient and trying to do a resection will be far less than our intention to treat survival for the patients that we enter into neoadjuvant therapy and transplantation per our protocol with de novo disease. Now, we discounted the hemochromatosis in this patient. And in fact, I forgot to put it on the slide, and Daniel had me add it back on last night. But it's the only disease that really does matter when it's underlined with these patients is primary sclerosing cholangitis, because those patients, we detect the tumors much earlier. They're oftentimes multifocal, and our intention to treat survival is much, much better. And as is our results after transplantation. So we consider neoadjuvant therapy and liver transplantation the treatment of choice for patients with cholangiocarcinoma arising in the setting of PSC. And for de novo cholangiocarcinomas, I'm still an advocate for resection. But when we estimate that the likelihood of achieving an R0 resection multiplied by the survival achieved with an R0 resection has to exceed or even at least equal or even be comparable to that what we achieve with liver transplantation. And so that's the way that we go about making a decision. Hey, so when I'm talking with Dave Nagorny and he's looking at, and we flip cases back and forth all the time, you know, first of all, I know what our results are with an R0 resection, but you know, the key question is what's the likelihood of achieving it? Because that's what determines your intention to treat analysis.
Well, that was my question. How can you assess that? Because we're notoriously bad at figuring it out, and especially in this disease, more than any other disease. Sometimes you don't figure it out until you're actually in there. So with MRI, even with spyglass, whatever it is, it's very hard to figure out who's going to have an R0 margin beforehand. And even until the final path is back, like Dr. Mercado said, because you have this perineural invasion and it tracks up along the duct. So how do you make that assessment?
It's a guess, and you're right. It's a very imprecise science. And this was a case back in 2003, and our imaging is much, much better now. But even so, it's very difficult to predict whether or not you're going to have an R0 resection. Looking in the literature, you know, it's somewhere between 20 and 40% that that you don't achieve it. So like, you know, anywhere from 60 to 80% of people will achieve an R0 resection when they operate. But that's not with portal vein, common hepatic duct encasement, extension up the left duct, and caudate involvement.
Yeah, but I think that has to be an educated guess because, I mean, in Dr. Nagorny's series, he has a 92% R0 resection. So right. He must be doing something right.
Right, or he's sending more cases upstairs to us, and as you know, so you know, despite all that, Tim, we just had 4 or 5 experts on this call say that you know you would have a 20 to 30% chance of getting an R0 resection, and then adjusting the anticipated 5-year survival downward, which is our justification for going ahead with the neoadjuvant therapy. And Alan, you're absolutely right. I don't know if you want me to show the rest of this case, Daniel, but the other reason I should. Can I share my screen then?
Sure.
So we did treat him, and then what happened, of course, is we started to have a lot of problems, which is really something that's very common with this treatment protocol. He developed recurrent hemophilia and underwent right hepatic artery embolization at his home hospital. He had virtually every complication we can imagine, including recurrent cholangitis, gastric outlet obstruction, eventually requiring TPN. He went on to progressively narrow the main portal vein and developed portal vein thrombosis. He had prolonged hospitalizations with increasing debility. In August of 2003, we actually deferred his operative staging due to debility and the development of ascites. In November, we then went ahead with operative staging per our protocol. He had a very prolonged hospitalization, and due to his debility, we deferred transplantation. That was in November of 2003. We actually sent him home thinking that he would never come back. But he came back in March with resolution of his ascites and less debility. He did have complete portal vein thrombosis and was TPN dependent. And these are a couple of scans that were done at that time showing this is the hepatic artery, the portal vein, the superior mesenteric vein was patent, as was the splenic vein, but the portal vein going to the liver was not. With great trepidation, we decided to go ahead with transplantation. He had dense vascular adhesions, required a massive amount of blood and blood products, over 100 units of autologous and red blood cells. He had a very difficult common bile duct stump closure due to the radiation effect. He required a jump graft between the donor portal vein and the recipient superior mesenteric vein, along with our usual arterial reconstruction to the infrarenal aorta. We reconstructed the biliary tree as we usually do with the Roux-Y choledochojejunostomy, and did a gastrojejunostomy because of his gastric outlet obstruction. And amazingly, his only post-operative complication was a dehiscence, which we fixed on day 12. Fortunately, I was out of town. This shows the explanted liver with a considerable ductal necrosis in the hilus. Here's the right liver. Normally, this kind of area right here, we'll see a tattoo from the radiation effect, but we didn't really see it that much in this case. But amazingly, he did not have any residual cancer seen on microscopic examination through the entire hilus of the liver. His outcome is explanted liver, had no residual carcinoma, and he's actually alive and well 15 years after transplantation with no evidence for recurrent disease. And when Daniel asked me to present a case, I was just kind of wondering which case to present. And a couple of days later, this gentleman left his usual annual greeting card on my in my inbox at the clinic when he came for his annual evaluation. And so it immediately came to mind to show that. One thing I thought I could show you, just to give you an idea, I'm just going to skip to where we...
Can I just ask you a question? So was it right that he left in November of 2003 and then he came back in March of 2005?
Yes.
Wow.
And believe it or not, one time we had to do the operative staging right after we completed neoadjuvant therapy, and we have never seen progression between neoadjuvant therapy and transplantation. These are our results overall. We've actually now entered 400 patients with neoadjuvant therapy and our overall survival, but that includes a large amount of PSC patients. When we look at the de novos, we've done 148, 117 staging operations and 84 transplants. The 26% of our patients with de novo cholangiocarcinoma end up staging positive, whereas it's only 14% of those with primary sclerosing cholangitis. And then if you look at the intention to treat, so these are all the patients with either a PSC shown in green or de novo shown in white. And as you can see, our 5-year survival is currently at 41% and 32% at 10 years. This includes all the patients that fall out at staging or develop disease progression before or after operative staging. And then when we look at the results after transplantation, you know, it's not great. It's only 60% at 5 years and 47% at 10 years, but we can certainly achieve long-term survival. And, you know, we generally look in transplantation as trying to achieve 50% 5-year survival being the absolute minimum for success. So we're flirting with it a little bit at 58% with de novo cholangiocarcinoma, but overall, you know, we felt it was in this patient's best interest. I learned a lot on this case, though, because in reality, to drop 100 units of blood in an operation like that requiring a portal vein reconstruction in an irradiated field probably wasn't the wisest thing to do, and it's one of the reasons that this case is on my top 10 list.
After the case, you needed a stent for your coronary artery. So I would like to ask you, if I may, there's a database analysis from the ELIDA database in Europe that questions the need for neoadjuvant therapy in these patients, because they say that the Mayo Clinic selection criteria is so strict that you are really picking the winners and you can just transplant them without the neoadjuvant therapy based on their analysis of patients who underwent transplant without it. So what would be your opinion about that?
That's absolutely wrong. What we've shown with neoadjuvant therapy is that 50% of our patients do not have any residual carcinoma in the explanted liver that's detected, you know, by microscopic examination. The recurrence rate when there's no residual disease is very, very low. I think we've only had one de novo recurrence and one recurrence in PSC for patients that have had no residual disease. And we published that in the Journal of American College of Surgeons a couple of years ago through the Western Surgical Association. Almost all the recurrences are in the patients that have residual disease. Furthermore, historically, not only has transplantation been fraught with disease recurrence, but even in patients with incidental cholangiocarcinoma, there are 3 studies, one from Canada, one from the UK, and another from the United States. Even people that undergo liver transplantation for primary sclerosing cholangitis and have cholangiocarcinoma detected in the explant have a very, very high recurrence rate. So back when I was a fellow in the early 1990s, late 1980s, we did everything possible to rule out an underlying cholangiocarcinoma because that was an absolute contraindication for transplantation. And without neoadjuvant therapy, I believe it remains so today. I think the primary treatment actually is the neoadjuvant therapy. We're giving doses much higher than you would normally give and allow the liver to survive. And the reason we can get away with it is because we switched the liver. So the liver, as Alan was mentioning, to me, the liver transplantation is pretty effective adjuvant therapy.
Okay. Given the experience built at the Mayo Clinic, a French group, a large multi-institutional French group, developed a randomized study of patients with resectable hilar cholangiocarcinoma, and they allocated them to groups of resection and transplantation. Could you tell us about the rationale behind the study, what has happened to that study? Because that study has been going on for at least 10 years.
And in full disclosure, I served as an advisor to the study, or at least to the design of the study, but I have not been involved in the data. But I don't think they've been able to complete the study due to difficulty with recruitment. Perhaps one of you, or do you know more than me?
Well, I think that they have been getting issues with their ethics committee because they have been losing some resectable patients because of progression during neoadjuvant therapy or fallouts during neoadjuvant therapy, and they have not been able to transplant them. So I think that the ethics committee is asking them some questions about whether they should keep going or just stop the study.
Yeah.
Does anybody has any other question right now? Or?
I do have a question, Dr. Rosen. So you mentioned that you transfused the guy with 69 units of autologous blood. So that means cell saver. Did you guys use cell saver for these cases, even with this no risk of sticking? I
don't think so. We use cell savers on all of our transplants, including those with hepatocellular carcinoma. I think if the tumor is going to get into the blood and go into the cell saver and get circulated, it's already into the blood. And you know, many of these cancers are already systemic diseases. And when you're 100 units down, I was just happy to get out of the operating room with any blood in his vascular system. We have, as you can tell, we have tremendous support from our anesthesia and critical care team. And I realize that our blood banking resources, exceed what you would be able to have at almost any other institution in the US or in the world for that matter.
So Chuck, is there any type 4, so would you operate on a type 4 lesion only in the setting of no vascular involvement or focal portal vein involvement? I'm trying to wrap my head around this, 70% estimation of an R0 margin.
Sure. Where I would operate on a type 4, if we know that there's lymph node involvement, let's say the EUS demonstrated lymph node involvement, and we feel there's then we're back, resection is the only option, and discussing that with the patient, whether they want to undergo that. So if there were, lymph node involvement by the EUS, for instance, even though microscopic, that would rule them out, I would go ahead with an attempted resection if it all seemed possible. The other things, there might be situations depending on the patient's blood type, for instance, or their suitability for transplantation that might, shift you one way or the other. But I think you have to take kind of a wide view. It's really what's in the patient's best interest with an intention to treat analysis, and not get drawn up into the fact that you might achieve 60, 70, or even 80% 5-year survival with an R0 resection. And many of those survivors at 5 years have cancer. And as you could tell by our data, the people that because we've got, a lot of patients following out now to 10 years. And when they make it to 5 without cancer, they're cancer free.
Mm-hmm. I would like to ask Dr. Sakamoto, actually.
Yes. Congratulations for your excellent results of liver transplantation for cholangiocarcinoma. I would like to ask you how do you manage the lymph node metastasis? So peripancreatic lymph nodes or in the nodes in the hepatoduodenal ligament, how do you dissect these lymph nodes during transplantation?
It's an excellent question. We do an operative staging prior to the transplantation, and we don't take the hilar nodes, but we do take the node, a line over the common hepatic artery at the takeoff of the gastroduodenal. And we'll also go behind and take a pericholedochal node. Oftentimes that's not even there because of the radiation therapy or the brachytherapy, it's been obliterated, but we'll take some tissue there nevertheless, and then we'll biopsy anything else that looks suspicious. Anybody that has lymph node metastases or any spread outside of the liver or even intrahepatic metastasis, we will not transplant. They fall out, and unfortunately, those patients are, as you can tell with all the ductal necrosis and the hilus, they'd be impossible to resect, even by the best surgeon that you could ever imagine can't do that because you can't reconstruct it. And once we explore somebody for resection, we can't enter them in the protocol because our recurrence rates are so high when we do that.
And I think that an important technical point during this operation is that unlike other liver transplantations where you are looking to preserve the bile duct and you're looking to preserve the common portal vein, and you're looking to keep all these structures for reconstruction, in the liver transplantation for hilar cholangiocarcinoma during total hepatectomy, the dissection is done to the closest of the duodenum, and you go as low as you can, and all the tissue of the hepatoduodenal ligament is going with the liver to pathology. So instead of doing a lymphadenectomy, you are doing an en bloc resection. And I think that's an important oncologic concept of this operation. I wanted to ask Dr. Sakamoto about precisely about the lymph node involvement. I mean, this is something that you don't do routinely before resection. I mean, you don't do an endoscopic ultrasound and you don't sample the lymph nodes.
Yes,
but you still go ahead with resection. What's the difference in the outcome for an R0 resection in a patient with negative lymph nodes, an R0 resection in a patient with positive lymph nodes? And what would be the outcome if you decide to stop the resection because there's a positive lymph node and the patient remains unresected?
Mm-hmm. So your question is about the management of the nodal metastasis patients. And yes, we just do the CT scan before operation and do the FDG PET sometimes. And in the operation, we always do the en bloc dissection of the lymph nodes of the peripancreatic and in front of the common hepatic artery and hepatoduodenal ligament lymph nodes in en bloc fashion. And yes, if there is a lymph node metastasis, the 5-year survival will be less than 30%. But no metastasis, and if we can obtain R0 resection, we can obtain more than 50% of the 5-year survival, even in patients with advanced cholangiocarcinoma, I think.
But you would not stop a resection because of a positive lymph node.
We do not. We never stop resection even if the patient has the regional nodal metastasis. But the patient has the para-aortic node metastasis. It's the metastatic in the M1 metastasis. We stop the operation sometimes.
Okay, just for a para-aortic, which would be an M1, but not for any other. Which for liver transplantation, you actually have to stop if you have any positive lymph nodes, and that's a huge difference in that sense. So, Dr. Rosen, in this operation, unlike resection, again, you sample the distal margin of, well, sometimes you do that in resection, but you sample the distal, or yes, the distal margin of the bile duct. What would you do if the margin is positive? How would you assess that? What's next after that, Dr. Rosen?
Because our criteria require that the tumor be above the cystic duct and restricted to the common hepatic duct and not extend down to the common bile duct, the common bile duct margin is almost always negative with the de novo cholangiocarcinoma. One time we took a frozen section, it was read as positive, and we actually did the pancreatoduodenectomy, but then it wasn't, it was probably a false positive, or it was our high-grade dysplasia. Where it becomes more important is the patients with underlying primary sclerosing cholangitis, which is about 2/3 of our practice. And there, that margin is positive about 10 to 12% of the time. And when we know it's going to be positive, because we now do brushings and a blind biopsy of the common bile duct during the preoperative evaluation. And if we find microscopic disease, then we plan to do the transplant with an en bloc pancreatoduodenectomy. If that's negative, and then we take a frozen section at the time of transplantation, which we do with our PSC patients, and there's about a 12% chance that that'll be positive, we've gone ahead with the sequential pancreatoduodenectomy, and we've done it at the same time. In total, we've done about 20 pancreatoduodenectomies. It's a pretty major undertaking in an irradiated field with an arterial reconstruction, but we've got about 40% or so 5-year survival. The patients that we did that en bloc, we were planning to do the pancreatoduodenectomy, have had a little bit better outcome with fewer recurrences, but not that much better. It's clearly pushing the envelope. It's a questionable thing to do. We only pick the best patients that are young and otherwise healthy. And but when you're doing the transplant and you don't think it's going to be there, and then it is there, you know, there's really nothing else to do but just to kind of bite the bullet and go ahead and do the pancreatoduodenectomy. We've done them all at the same time, but if there are 4 of us surgeons that do the transplants at Mayo Clinic now, if one of us that's not comfortable doing the Whipple procedure at the time of the transplant, we've decided that, you know, they'd wait till, you know, I came back into town or something to do that part of the operation. We do it a week later, but we haven't had to do that so far.
So would that be oncologically adequate just to leave the positive margin there and then come back? Or do you think that would add any risk of seeding to the operation? Is there a difference?
I think there is. I can show you real quickly just some brand new data that we have. So here's our overall survival, which is about 40% at 5 years of the 20 patients. When we look at the patients on top that had an en bloc one, even though the survival is the same here, early on it was a little bit better than the ones that we did sequentially with a positive margin. And if we look at those cases, the recurrence rates, there were 6 when we cut through the duct or cut through the microscopic tumor, and there were only 2, probably 1. One of these recurrences was endometrial, and there's a little bit of controversy whether to count that or not. So our recurrence rate there is only 1 or 2 out of 7 versus 6 out of 13 with the other group. So, you know, I don't think when you're going to only find a positive margin in 12% of the patients, knowing the morbidity and potential mortality of combining the Whipple procedure with the transplant, I certainly would advocate an en bloc pancreatoduodenectomy for all of the patients with cholangiocarcinoma arising in PSC.
And what would be the rate of pancreatic fistula in those cases?
I think, you know, we've had some type of a leak in about half of the patients.
Somebody wants to add to that question or ask another thing? Dr. Pablo? Dr. Contreras?
I just want to make a comment because I think it's very important for our audience to remind us, this is beyond getting R0. This is not like doing a bigger operation to get R0. This is a patient that probably has had enough chemotherapy, radiotherapy, brachytherapy. So you are basically dealing with tumors that they stayed in a locally advanced way, but they did not progress. And this is very important to comment because I don't want to send this message that, okay, we're going to do an R0 resection now and we're going to do a lot of liver transplants. So coming back to my first question, Dr. Rosen, what would you advise if we don't have the Mayo protocol, the complete Mayo protocol? Do you think we should go ahead and try to achieve R0 with liver transplantation or any combination or part of the adjuvant therapy?
Without completion of neoadjuvant therapy with an aggressive protocol such as the one that we proposed, I would not do a transplant. The results with transplantation, even though you do achieve an R0 resection without neoadjuvant therapy, are terrible. And whether or not that's because of the immunosuppression or because of the selection or a combination of both, because you're already choosing patients that have unresectable disease or, you know, potentially unresectable disease, and then you're combining that with the immunosuppression afterward. It's just, I think it's an absolute contraindication, particularly because of those series, even though they're small, that show that incidental cholangiocarcinomas that I mentioned earlier that are found in the explant that we didn't know were there prior to transplant have such a bad prognosis. The only exception The only exception that I would consider that would be with a polypoid cholangiocarcinoma, which I actually did one as a fellow, and I didn't want to cut across the duct because it was so large, and Rudy Crom made me do it, and we pulled out this polypoid tumor, and she died from cardiac disease 10 years later. But I actually wanted to give her post-operative radiation after a transplant, which I think would be pretty bad to do too because of the arterial complications. But anyhow, she did well, but those are very few. So with the exception of a polypoid tumor, I would not do it. And even with a polypoid tumor, when we're presented with those, we've gone ahead with the neoadjuvant therapy.
So something that it's, I think, oncologically important is two things, and I'm going to refer to just one. Do you think that the oncological therapy that these patients are getting is the resection or the radiotherapy? Because we talked about liver transplantation for colorectal metastasis on Wednesday, and we looked at a bunch of cases that had severe complications after liver-directed therapy because of hepatic artery pump or just liver damage from chemotherapy, and then underwent transplantation because of chronic liver disease with some or minimal disease. Do you think that the oncological therapy that these patients are receiving is the radiotherapy, or is it the resection, or is it the combination of the two? Because the patients would not survive radiation without the transplantation.
Right. It's obviously a combination of the two, but I think the most significant mode of therapy is the neoadjuvant treatment. It achieves, it's the only thing that you're doing that it allows you to have a tumor-free explant. And, but the dose that's required is so high that the liver is destined to die or to have biliary necrosis or complications as a result of that. And so doing the transplant obviates or avoids those complications of the neoadjuvant therapy, and it cleans up the patients that still have microscopic viable disease. And so, you know, those patients have a higher rate of recurrence, but they don't all recur. In fact, most of them don't. And so I consider the transplant operation, even though I'm a surgeon, I consider that we're administering adjuvant therapy. Now, if you were to ask Greg Gores, my close colleague in transplant hepatology, who's been, you know, my co-conspirator with this effort, he actually disagrees with me a little bit, but he's just absolutely wrong. I mean, when you look at our data, it may be a little crass to say that, you know, it's the neoadjuvant therapy is the primary treatment and the transplant's the adjuvant therapy, but I think you really have to look at it that way.
I wanted to ask, because Dr. Pavlik is here and he just talked to us about intrahepatic cholangiocarcinoma, and we have Dr. Sakamoto, Chuck, Alan, and Dr. Mecaro. There's a trend or a current effort, an ongoing effort of transplanting intrahepatic cholangiocarcinoma based on a retrospective analysis of Spanish data and then a multi-center cohort and an international effort. And there's an ongoing protocol for transplant for intrahepatic cholangiocarcinoma. But the thing is that for hepatocellular carcinoma, you have non-invasive diagnosis. But for intrahepatic cholangiocarcinoma, you need to actually have tissue diagnosis in order to treat it. So in this protocol, you are absolutely avoiding transperitoneal biopsies for these lesions. Do you think that is going to impact our effort for transplanting intrahepatic cholangiocarcinoma? Is that going to change things? The fact that we may be creating a seed of transperitoneal disease?
I'm not sure I'm in a good position to answer it, but I will. I think it will adversely affect your results. We actually looked at transperitoneal biopsies in our resection experience. And unfortunately, when we wrote it up, we looked at the results with overall 5-year survival. But because the recurrence rates are so high, as we've already discussed, even the patients that are alive at 5 years, many of them have cancers. It was really hard to discern things. But if you actually look at the two curves, the people that had a transperitoneal biopsy or an FNA of the primary tumor really had less survival you know, died a little bit earlier. It's the mistake, you know, if you did an operation and you looked at 120 years survival and you compared two groups, it's going to be the same because nobody lives to 120 years. And so that was the problem, I think, with that study. But unless the chemotherapy for an intrahepatic cholangiocarcinoma, if those potions are so magical that they can treat the systemic disease and eradicate it, I think those patients aren't going to do that well. Our only real experience with intrahepatic cholangiocarcinoma and transplantation comes from inadvertently transplanting somebody with an intrahepatic cholangiocarcinoma. And even a 2-centimeter lesion doesn't do anywhere near as well as it does with an hepatocellular carcinoma. It still gives you acceptable results, but once they get above 2.5, 3 centimeters, the recurrence rate is very high. So we'd have to have some type of highly effective neoadjuvant or adjuvant treatment to avoid recurrences.
Yeah, just to follow up on that, if I remember in that study from Spain, they looked at very early 2 centimeters or less versus larger tumors, and they showed that in the very early, I think the 5-year survival was about 70% with transplantation. Then it was lower, 35 or 40% for the lesions that were larger. But I mean, it was a very small study. I think there was like 25, 30 patients in it. And some of the patients that were included in the study were patients who were thought to have HCC as the indication. And then after they took the specimen out, it ended up being ICC. So, the other thing, at least based on some data that we've looked at, even in very small ICC, the incidence of lymph node metastases is still in the range of probably like 15%. And if you look at the pattern of recurrence for intrahepatic cholangiocarcinoma, we published a paper recently in JAMA Surgery showed that very early recurrence within 6 months of resection is actually quite high, even amongst a subset of patients who have small tumors. And so I think that intrahepatic cholangiocarcinoma is kind of, it's a different beast. I think it's more of a systemic disease. I kind of think it's more like pancreatic adenocarcinoma. I think most people who present with intrahepatic cholangiocarcinoma have systemic disease when they present. So, I agree with Chuck. We need to have a more aggressive systemic option for these patients before, we can move to transplantation. Because I think what Dr. Rosen's data would show is that he's saying that, surgery's adjuvant therapy for the hilar lesions because he has very effective neoadjuvant therapy. We don't have that very effective neoadjuvant therapy right now for intrahepatic cholangiocarcinoma. And until we do, I think we have to proceed slowly with considering transplantation for these patients.
I really agree with you. And I wanted to make a comment about the neoadjuvant therapy for ICC, if you can call it that, and then ask Dr. Sakamoto a different thing. There's a series of cases, really. It's not a large study, but there are some case reports in France of using Y90 as a neoadjuvant radiation therapy for these large ICCs, obviously for patients without liver disease, and then take them to transplantation afterwards. And I think that's the start of an effort to replicate this wonderful protocol. But Dr. Sakamoto has a wonderful paper on the classification of intrahepatic cholangiocarcinoma, and I mean, his system really clearly differentiates between the stages, unlike the currently available. And would you like to comment to us, Dr. Sakamoto, about that system
thank you
for
very
early
much for
intrahepatic cholangiomas?
Yeah, thank you very much. But I think for biliary cancer, the capecitabine will be only the drug which will be approved to have the effect of the adjuvant chemotherapy. And I think there will be no evidence proved by the phase 2 trial as for the biliary cancer as adjuvant chemotherapy. So in Japan, we do not do the neoadjuvant chemo for biliary cancer, including cholangiocarcinoma up to now. We just do it as a style of the clinical trial we are now studying about the neoadjuvant chemotherapy for biliary cancer as a style of the clinical trial. So we can say that yes, the chemotherapy can be standard therapy for hyalocholangio or intrahepatic cholangiocarcinoma. We can say that now, up to date.
And would you like to comment about those very early cholangiocarcinomas, intrahepatic cholangiocarcinomas that are less than 2 centimeters? I think the study showed that the lesions that were less than 2 centimeters had a less likelihood of having vascular invasion of the pathology, I think.
Yes, yes. As for the small cholangiocarcinoma, for small ICC, there's some chance of the cure of the disease by resection, and by transplantation also. Transplantation should be indicated in these very early biliary cancers, like ICC less than 2 centimeters, or a very early stage hilar cholangiocarcinoma, not for advanced cancers, I think.
Thank you, Dr. Sakamoto. So, Chuck, you mentioned that you had to do a portal vein reconstruction in this case, which I think that we all have a clear answer to that. But you also did an arterial reconstruction in the case. So what would be the rationale behind that? Because when this patient was alive almost 2 years after radiation therapy, so I can only imagine the quality of the hepatic artery that you found.
I don't remember finding it. It was, everything was bleeding. So, but what we found, as you know, that we have about if we do a common hepatic artery to common hepatic artery anastomosis, we have about a 20% chance of having a late stenosis or occlusion, which can be disastrous in liver transplantation. We have that same complication rate with the portal vein. The portal vein is easily treatable with a transhepatic portal vein angioplasty and stent deployment. We've actually never lost a graft due to that complication. But with deceased donor transplants, to avoid any problems with the artery, we've gone to use of an iliac graft to the infrarenal aorta. Occasionally, one of my colleagues will not do that. And then at 6 weeks, 8 weeks later, all of a sudden the ultrasound changes. And to go back and try and fix that problem is really tough because you can't feel the pulse in the liver, in the hilus transplanted liver. You have to dissect out that arterial anastomosis, which is right next to the portal anastomosis. And it's also, you know, in a radiated field, at least on the recipient side of it. And having had to go back and fix one of those will change your mind completely about not doing it in the first place. When we do living donor liver transplantation, we can't afford that size mismatch. And so we just go ahead and use the donor hepatic artery to the recipient common hepatic artery in an end-to-end fashion. But we have a 20% rate of late vascular stenosis with that effort. Now, using an iliac graft does give you it does have long-term consequences. Sometimes that iliac graft will develop arterial sclerosis or go down, and you'll have to replace it. And we've had to do that a couple of times, both in our cholangiocarcinoma and non-cholangiocarcinoma patients. But it's a pretty well-recognized alternative to a direct arterial anastomosis.
I visited Toronto a few years ago, and they started doing liver transplant for hilar cholangiocarcinoma. Something that Dr. McGilvray observed is that he was doing more and more resections for hilar cholangiocarcinoma because he was getting more cases. But one of the things that they were worried about was the length of the portal vein that they needed from the deceased donor. So would you give us some tips or tricks about the portal vein reconstruction in these cases? Because you have to go really low for the oncological purpose of the resection, and you have a short stump of the recipient portal vein. So how would you manage the reconstruction of the portal vein from a deceased donor or a living donor?
Yeah, I mean, we try and clamp that portal vein right above the pancreas. In fact, I'll free it up from the pancreas, and there's a kind of some ligamentous tissue between the portal vein and the artery anterior to it. And I divide that, and it gives you some mobilization. But even though most of our livers are taken out with a pancreas for procurement, so we have a little bit shorter of a portal vein, you hardly ever have a problem making it reach. When I mobilize the entire cava when I do a liver transplant, and so even if we're sewing the donor suprahepatic vena cava to the left middle hepatic vein trunk, when we're doing that, you can pull it down and make it reach. And if there's any question, an alternative is to do an end-to-side anastomosis between the donor suprahepatic vena cava and the recipient vena cava below the hepatic veins. That tilts the liver up a little bit, but that's an alternative as well. I can't remember ever having a problem getting that portal vein together. Now, sometimes I've had a problem getting good control of it on the recipient side. That brachytherapy will kind of weld the common bile duct onto the portal vein, and I've had to dissect the common bile duct off the portal vein with a scalpel. And that can be a little bit harrowing because you never know, you know, you'd like to see the portal vein from the outside, to see it from the inside, and then have to try and fix it. in an irradiated portal vein isn't all that much fun. And so, you know, a lot of times it looks totally normal and people say, you know, what are you making such a big thing about it? But other times it can be pretty awful. I don't remember any cases you were with me, Daniel, but occasionally that dissection of getting that duct off of the portal vein is really tough.
And with a living donor, would that change things because you have a short right portal vein or left portal vein?
With the living donors, we used a segment of deceased donor iliac vein to make up the difference. And another reason that we did that was it gives you a shelf of vein because the stenosis occurs on the recipient vein. So it gives you a shelf of vein so that you can put a stent in without occluding the anterior posterior portal vein. If you don't have that interposition graft and you put the stent in the anterior right portal vein, you might occlude the posterior one or vice versa. But in full disclosure, our results with living donor transplant are not all that. And we found our most recent data analysis, which is not published, but you can still see it a little bit in a paper by Akun Tan that was published in the Journal of American College of Surgeons just this past year from the Western, that our results with living donors are not all that great. The shorter waiting time seems to, you know, it doesn't allow you to select the patients that are going to do well. And so it's better to observe for the biological behavior of the disease. And by the time you observe them for 6 months, you might as well go ahead with a deceased donor transplant based on the US allocation schema. So we've actually temporarily suspended our living donors for cholangiocarcinoma. We've done that since you left, Daniel. And with the wider geographical sharing, we're actually getting our cholangiocarcinomas transplanted pretty reasonably with deceased donors.
I think that we have a couple of minutes left. If somebody wants to make any concluding remarks or any last minute question or comment. Dr. Pavlik.
No, all I would say is thank you very much. I always learn something when I'm with all of you, my esteemed colleagues. And, you know, I think, you know, as Dr. Rosen highlighted, whenever you bring like 4 or 5, you know, experts together, you know, it's always interesting to hear different people's perspective and takes on these cases. But I appreciate being involved tonight.
We appreciate having you. And Doctor, thank you, Sakamoto. Dr. Contreras, muchas gracias.
Thank you very much.
Muchísimas gracias, Dr. Mercado, Chairman. Chuck, thank you very much. I mean, I think it has been a fun experience for everybody, and we appreciate your participation in our meeting, and we thank you to the audience for connecting. Thank you very much to everybody.
Thank you. Good to see all of you.
Good to see you.
See you.